Welcome to our second video on diseases of the colon. Let's get started. So here's an overview of what we'll be covering in this lecture. We'll be covering diverticular diseases, angiodysplasia of the colon, acute and chronic mesenteric ischemia, and ischemic colitis. So let's start with diverticular disease. So when we're talking about diverticular diseases, this includes diverticulosis and then diverticulitis, as well as bleeding of the diverticulum. Diverticulosis of the colon is a condition in which many false diverticula form. So they're outpouchings of the mucosa and the submucosa through these focal areas of weakness within the muscularis layer. And the area this most commonly occurs in is the sigmoid colon. Now, the population at risk is older adults and anybody with increased intraluminal pressures, so like chronic constipation, a low-fiber diet. And the reason is because that high luminal pressure just further pushes that mucosal layer outward. Other risk factors are a high fat and red meat consumption. Now, the mere presence of these diverticula does not produce symptoms, and hence uncomplicated disease is usually asymptomatic. Now, symptoms mostly develop when complications such as diverticulitis, so inflammation of the diverticula, or when it bleeds. Now, diagnosis of uncomplicated diverticulosis can be made with barium enema, and that will show signs of a barium-filled outpouchings. And colonoscopy can also be helpful, and that is actually the most accurate test. And an X-ray is usually normal. You're not likely to see anything with that. And management includes taking a high-fiber diet, and that can actually help prevent the condition from getting any worse. So once you've diagnosed it, go to high fiber, and that can help in some cases. Now here's an endoscopic image of two diverticula. And they look like these outpouchings in the actual colonic wall. So this particular image shows a barium enema. You can see multiple colonic outpouchings, and that would suggest diverticulosis. Now, diverticulitis occurs when fecal or food impaction produces friction, and then it injures the diverticulum. So again, that diverticulum is already there. Then something causes injury, like your food, and that causes microperforations of the diverticular wall. This leads to inflammation or infection of the diverticulum, hence the itis in diverticulitis. Now, since diverticulosis is most common in the sigmoid colon, the typical presentation of diverticulitis is in the left lower quadrant. And so there will be pain in the left lower quadrant, in addition to fever and leukocytosis, those elements that you would expect if you're infected. Now, a complicated diverticulitis is said to occur when that inflammation gets severe enough to cause intestinal obstruction, or even a fistula, or if it perforates, or if there's formation of an abscess. Now, a CT scan is the investigation of choice in any patient in whom you suspect diverticulitis. And that would show focal thickening of the colonic wall due to inflammatory edema, and there can be pericolic fat stranding. Although barium enema is a useful investigation in uncomplicated diverticulosis, once the diverticulitis develops, the barium enema is no longer safe. So once they get the itis, then you don't want to do a barium enema. And the same is actually true for a colonoscopy as well, because you're worried about causing a perforation of that inflamed colon. Now, treatment of diverticulitis is conservative, at least for uncomplicated cases. And what you would do there is just give IV antibiotics, IV fluids, and just let the bowel rest. So they won't be eating anything. So in some cases, it's very similar to how you would treat pancreatitis. Now, most cases resolve with simply those measures alone. However, what you're going to want to do later is follow up with a colonoscopy, and that's to ensure resolution. And then with that colonoscopy, you can go back and look and find the diverticulum. You can say, okay, this patient did have diverticulitis because we find the diverticulum. And oftentimes, because of that acute episode, you want to rule out something more sinister like cancer. Once again, the colonoscopy is helpful there. Now, this CT image shows encircled focal thickening of that colonic wall. And you can actually see that pericolic fat stranding. And what does this suggest? Diverticulitis. So we talked about conservative management, but what about surgical management? Well, Surgical management is indicated when there's any complicated diverticulitis, or if that diverticulitis wasn't responsive to the IV fluids and IV antibiotics that you gave them, or if the diverticulitis just keeps coming back. The other complication of diverticulosis is bleeding. So there's two things that we know now about diverticulosis. It can cause symptoms by virtue of causing diverticulitis, inflammation, or simply bleeding. And this bleeding presents as painless hematochezia. And the source of bleeding is a weakened vasa recta in the diverticular wall. And since the bleeding is arterial, it can sometimes cause hemodynamic instability. And diverticular bleeding is the most common cause of gross lower GI bleeding in adults over the age of 40. And how would you confirm that the bleeding is from the diverticulum? Well, colonoscopy. And thankfully, most cases resolve spontaneously. Let's do a quick question to review. A 69-year-old man is brought to the emergency department due to severe left lower quadrant pain for the past day. He has a long history of constipation. Vital signs are significant for a temperature of 39 degrees Celsius. What is the best initial step in the evaluation of this patient? Well, this elderly man presents with fever, so 39 degrees Celsius is a fever, and he has left lower quadrant pain for 1 day, and a long history of constipation. So all of those clues point to the diagnosis of acute diverticulitis. And the best initial step in the evaluation of a patient with diverticulitis, or in whom you suspect diverticulitis, is an abdominal CT scan. And just as a secondary part of that question, what will you see on that CT scan? You would see thickening of the colonic wall and pericolic fat stranding. And what are two studies that you do not want to perform in this patient? That would be a colonoscopy, because you're worried about rupture, and a barium enema. The next topic is angiodysplasia of the colon, is a tortuous dilation of submucosal veins, and this most commonly occurs in the right colon. The most commonly affected population is the elderly population. Angiodysplasia is more commonly seen in patients with aortic stenosis, or those patients with von Willebrand disease, or those with end-stage renal disease. A lot of times it can remain asymptomatic for years, or even cause painless, intermittent, low GI bleeding. Now, in contrast to arterial bleeding, like we discussed with diverticular disease, the source of bleeding here is the veins, specifically submucosal veins. So the bleeding is usually small volume. So it's not likely to cause hemodynamic instability that can occur with diverticular bleeding. And how do you diagnose angiodysplasia? Well, a colonoscopy. And that way you can actually visualize the tortuous veins. And most of them resolve spontaneously. So let's take a look at an endoscopic image which clearly shows an angiodysplastic lesion. So what you see there are submucosal veins. Now let's talk about mesenteric ischemia. And this is actually going to be grouped into two portions, the acute and the chronic. So acute mesenteric ischemia occurs due to acute blockage of mesenteric vessels. The most common cause of this abrupt acute blockage is emboli. For example, a thrombus that forms in atrial fibrillation and then embolizes. However, formation of an arterial thrombus over atherosclerotic lesions in the mesenteric vessels can also cause acute blockage and downstream ischemia. In other words, thrombus that's local to the mesenteric arteries or one that embolizes from elsewhere in the body can both cause acute blockage and acute mesenteric ischemia. So what vessels are we talking about? Well, the most common are the supramesenteric vessels. So you remember you've got the celiac trunk, the superior mesenteric artery, and then the inferior mesenteric artery. So the one that most commonly experiences mesenteric ischemia is the superior mesenteric. How does this present? Well, the classic feature is acute abdominal pain. It hurts super bad. In fact, it's described as out of proportion to what you would expect based on the exam. And diagnosis can be made using CT angiography. And that makes sense why you'd want to use angiography specifically, because here we're talking about these vessels, and you want to be able to see them. So simply doing a CT scan isn't really going to cut it. Now, how do you treat it? Well, treatment includes IV fluids and antibiotics, and you're also going to want to treat any underlying arterial obstruction using heparin, and that will, of course, help halt the propagation of the thrombus. But you can also use something like embolectomy to revascularize the ischemic region. And that's fairly intuitive. If it's blocked, you want to open it up. Now let's discuss chronic mesenteric ischemia. Chronic mesenteric ischemia is also sometimes called intestinal angina, and that term actually makes it quite easy to understand. So just like angina pectoris is caused by atherosclerosis of coronary arteries and causes recurrent ischemic pain with increased demand, such as during exertion, well, the same thing is true for chronic mesenteric ischemia. It's caused by atherosclerosis of the mesenteric arteries instead of the coronary arteries, and it causes ischemic pain associated with increased demand. And what increases demand on your intestines? Well, digestion and absorption. Basically, guts just doing what they do. So classically, a patient with chronic mesenteric ischemia has a lot of risk factors, those that you would associate with atherosclerosis. And then they would have recurrent postprandial pain. Again, that's because after they eat, they get that increased demand, and then they get that intestinal angina. And they can sometimes describe it as a crampy abdominal pain. And because the pain is induced by eating foods, then patients experience food aversion, and sometimes they get significant weight loss. And that's a reasonable response. I mean, if it hurts really bad to eat, then naturally you're going to stop eating. Now, to confirm the presence of these atherosclerotic lesions and to evaluate the extent and severity of disease, of course, you're going to do CT angiography, very similar to acute mesenteric ischemia. Since the underlying pathology is the same as that of angina pectoris, then a similar treatment approach is followed, including risk reduction, for example, prescribing statins, antihypertensive drugs when applicable, as well as revascularization techniques. In addition, patients with chronic mesenteric ischemia need special attention to their nutritional support because, of course, they have food aversion. So you're worried about malnutrition and you're going to want to treat that. Now let's try a question. A 72-year-old woman comes to the physician due to 20 kilogram weight loss over the past 2 years. She experiences dull abdominal pain during every meal, causing her to eat less. She has a past medical history of peripheral artery disease and myocardial infarction. What is the best diagnostic test for this patient's current condition? Okay, this elderly woman lost 20 kilograms and has dull abdominal pain during every meal, and now she's eating less. That's classic chronic mesenteric ischemia, or intestinal angina. And this condition is more likely given her history of peripheral artery disease and an MI. And how do you diagnose this definitively? CT angiography. And that will show you the atherosclerotic narrowing of the mesenteric vessels. Now let's talk about our last disease, ischemic colitis. Ischemic colitis classically results from non-occlusive ischemia. And that's occurring during low blood flow states, such as acute hypotension, hypovolemia, cardiovascular surgery, or shock, trauma, things like that. But there's no actual obstruction, it's just a low flow state. It affects the watershed areas of the colon, and so you're thinking about the splenic flexure and the rectosigmoid junction. And that's because those areas are located between the terminal branches of two major arteries, so of course they're vulnerable to ischemia whenever there's low flow or low blood flow. And it most commonly occurs in older adults and presents with crampy abdominal pain, followed by bloody diarrhea. So let's use this image now to better understand those watershed areas that are commonly affected in ischemic colitis. First, we can see the splenic flexure, an area between the terminal branches of the superior mesenteric artery and the inferior mesenteric artery. Second, we have the rectosigmoid junction, located between the terminal branches of the inferior mesenteric artery and the superior rectal artery. And those two regions are highly susceptible to ischemia in states of low blood flow. So how do you diagnose this? Well, it's usually made on clinical grounds, but then you confirm it with a CT scan, and that can show bowel wall thickening. Or you can even do a colonoscopy, which shows edematous friable mucosa. And a barium enema, if performed, will show thumbprinting due to mucosal edema. Okay, so how do you manage this? Well, management is supportive initially, so it includes bowel rest, so not eating, and then giving the patient fluids and antibiotics. Something more invasive like surgery and resection of portions of the bowel may be needed if there's any suspicion of actual infarction or perforation. Here's a CT image showing thickening of bowel wall indicated by that black arrow. And that's what you can see on ischemic colitis. Let's look at this endoscopic image now. And this is another patient with ischemic colitis. And note that edematous, boggy, and friable mucosa. All right, now let's wrap up with a board-style question. A 58-year-old woman is evaluated in the hospital for severe abdominal pain. She underwent a coronary artery bypass graft procedure 4 hours ago, and she lost a lot of blood. Her vital signs include a temperature of 36 degrees Celsius, a blood pressure of 100/80, a heart rate of 84 beats per minute, and a respiratory rate of 16 breaths per minute. The physical exam reveals diffuse abdominal tenderness with no rigidity or guarding. Abdominal CT scan shows segmental bowel wall thickening, while colonoscopy shows edematous friable mucosa. Which of the following bowel segments is most likely affected by this patient's current condition? A. Ileocecal junction, B. Rectosigmoid junction, C. Hepatic flexure, or D. cecum. So this woman has severe abdominal pain after losing a lot of blood after receiving a CABG, heart surgery. And the physical exam shows diffuse abdominal tenderness, but no rigidity or guarding. And the CT scan shows segmental bowel wall thickening, and the colonoscopy shows edematous friable mucosa. Those all point to ischemic colitis. And recall that ischemic colitis affects the watershed regions of the colon, and those are supplied by the most distal branches of major arteries. And those regions involve the splenic flexure and the rectosigmoid junction. So the correct answer is option B. And here's the slide reminding us of ischemic colitis and those watershed areas. Now let's discuss why the other options are incorrect. Options A, C, and D are incorrect because the ileocecal junction, hepatic flexure, and the cecum are not watershed areas. In fact, they're supplied intensively by the major branches of the superior mesenteric artery. And that concludes our lecture.